Welcome to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and with me today is Dr. Eric Topol. Really glad to have Dr. Topol with me. We've had the opportunity to chat in the past, but you may know of his work. Certainly, he's involved in a great deal of activities. He's director of Scripps Translational Science Institute. He's the chief academic officer. He also is involved with Medscape. He's professor of genomics. I mean, basically, Dr. Topol, I think the thing that's fascinated me about your career over the years is just how involved you are in so many things. You know, as a physician who's out there, and those of us in primary care who do this, does diversity, is that one of the things that really excites you?
Oh, no question. Unfortunately, I get bored very easily. So the more different and spicy, fun things, the better.
Now, when you look at what you're doing, and you've done a lot, I mean, I know the first time I knew of you was just reading your cardiology text and using it as a reference for my own patients. And years ago, we did an interview, and you were doing that, and you're involved, running departments. What of all the things you have done has been the most exciting?
Actually, of all the things, it was writing a book, this Creative Destruction of Medicine book. I never worked so hard on anything, but I was trying to put together the concepts for a whole new medicine, a blueprint for that, and in terms of being able to digitize human beings, which is where we're headed now. And when I started getting into that, I started to realize that it was almost like an epiphany how exciting medicine is going to be. And I wish I was back in medical school, but it's really going to move into a whole other era of individualized precision and getting each patient consumer much more actively engaged. So I think we're onto something really big.
When you think of what you do, we'll talk about the creative destruction of medicine. When you think about what you do with a book like that, in order even to write a book like that, there's so many levels of knowledge you must have. I mean, you took your clinical experience, you took your knowledge, you took what you know about genomics and what you know about medicine and how it works. In order to have that overview and kind of that grand scheme, it probably couldn't have been something you could have written in medical school, even if you were there right now, I would think. No,
you're absolutely right, Brian. I had to have had this kind of unique and getting back to the diverse experience of having worked a lot in genomics and then also in wireless medicine to appreciate. I used to say to people in our institute we're working on those two fields, and they say, "What, are you crazy? It's such disparate areas." And I said, "What do you mean? They're all about getting granular information on each individual." So it was really getting that experience largely over the last 7 years or so that enabled a new perspective.
And I think, the old concept that knowledge is never wasted is never truer than in your case where you're taking all this. So when you talk about the creative destruction of medicine, take us through it. As we got a lot of primary care docs out there. They're going to war each and every day trying to help their patients, doing what they can.
Right.
What do you see as changing, and how will their worlds change?
Well, just as there's unique pressures in healthcare today and an economic crisis, probably unparalleled, there's equally extraordinary capabilities now, new tools that we didn't have before to understand at the most precise level each individual's biology, anatomy, physiology, what the medical essence of each person. And that is something that really resets, and that's that creative destruction. The Clay Christensen is one of the masters of innovation, and he had the term disruptive innovation. This is kind of disruptive innovation to the fourth power, creative destruction. And that is basically, we couldn't do these things before. We couldn't sequence an individual's DNA, whole genome sequence, now in a matter of hours at an affordable cost. We couldn't have wearable sensors like Band-Aids or wristbands or all sorts of things that you can wear that they capture all the vital signs and virtually any metric that one can think of. And we didn't have portable scanners like a high-resolution ultrasound you could carry in your pocket that replaces the stethoscope. So all these things collectively are happening at the same time, and they're all superimposed on this amazing digital infrastructure with extraordinary bandwidth and almost pervasive connectivity and little devices and social networks. So it's just an amazing time, all this stuff converging, and the digital world finally getting into this medical cocoon.
You know, it's so funny. I think back the first time I interviewed, probably less than a decade ago, I was in a studio and trying to put on what was really exciting digital audio tape, and then that would actually have to be FedExed to someone who would get it, and then that person then would take it and they convert it. You get the idea. Now you sit here, you can talk, you put it on a computer, you send it out, it's transferred through the internet, and even in the in the world of broadcasting, it's changed. In the world of medicine, it's changed. But as somebody who is in there, I'm broadcasting, I'm seeing patients, I still see the same old world. I mean, I still see hospitals going, some good things, they're looking at quality metrics and quality indicators and core measures, but they're also still looking at case mix index and people being hospitalized and trying to bill for this service and that service. It seems to be holding us back.
Right, but you can already see your way through to bedless hospitals. Well, why do you need a hospital anymore when you can do all of this by remote monitoring in the safety, convenience, and lack of expense of one's own home? The only people you'd have in a hospital would be those that are intensive care units, or they're there just for a procedure or an operation. Otherwise, no need for a hospital. And why are we doing all these physical office visits when we could today have this done so much more efficiently remotely and use having all that data about the person transferred either before the visit or during the visit? There's just so many different ways to practice primary care medicine going forward. It's really an exciting transition that we're looking at.
Let's say somebody wants to do that. They're thinking, you know what, I'm ready. I'm young enough. I'm at this point in my career. Maybe the kids aren't in college. Whatever the reason, I'm going to take a gamble. I want to do this. I want to do this kind of medicine. Is it possible to do it yet?
Oh, yeah. I mean, there's already models around the country. I mean, one of the front runners has been this fellow Jay Parkinson, who started up Hello Health, and they rarely, as a practice, started out in New York, see a patient physically. They connect through Skype and FaceTime and, secure video or text messages to all their patients. And by the way, Cisco Health recently did a big survey of thousands of people. 70% of them prefer virtual visits rather than physical ones. And the Virtuwell, a company, did a really impressive publication in the journal Health Affairs, and they saved, on average, $88 per patient visit by doing it virtually, and uniformly the patients preferred that. So this whole idea that you have to be physically face-to-face, that's not necessarily the case. And you probably are well aware of the statistics. They're very sobering about the average office visit is 7 minutes, and nowadays, because of all this meaningful use, a lot of that time is typing on a keyboard. And the average person in the U.S. waits a little over an hour for that appointment. So we have to do better than that. We need a new model, and it's just happening at the right time that we can innovate out of this mess.
If you're just tuning in, you're listening to Primary Care Today on ReachMD. I'm Dr. Brian McDonough. I'm speaking with Dr. Eric Topol. Fascinating conversation, and let's pick up on that. I agree with you. Here I am at my hospital. I'm Chief Medical Information Officer. I know all this stuff, but I myself have learned, we have our ambulatory platform, and I basically go in the other room and type now because I'm realizing I was missing all the nonverbal and even verbal cues because I was too busy typing because I never took a typing course. I'm sitting there hunting and pecking and, not even looking at my patient. And part of what care is, for example, seeing a mother with 3 children and realizing that you're seeing the kids, but mom's depressed. And as a family doc, why are you depressed? Is it issues at home? You end up treating the other person because you're watching across the room. When you're looking at a keyboard and you miss all that.
I would think pretty quickly we can have this whole interaction be voice digitized and then have that go right into the text and EMR and not have to do any typing. That's just crazy stuff. That shouldn't be the case. But you're absolutely right. I mean, you want to have, whether it's parents, significant others, or whoever else is involved, you do want to be able to connect with them. The more the depth, the better. So these are all important. The human factor is what we should be concentrating on as physicians, and not all this other crazy stuff that gets in the way.
Let me ask you a tough question because I don't know your opinion on it, but certainly there's a lot of things with meaningful use in going through these things that are important. But it seems a lot of it has been driven thus far as collection of data that really doesn't necessarily give us much back in caring for our patients. In other words, okay, it's great. We know what pool of patients we're doing or what doctors are ordering and getting that data, but we're not really getting to use the evidence the way I really want us to. Do you find that to be the case?
Absolutely. I couldn't agree more with you on that. And we have to do a much better job on that. I think that will be the case because of the unique access that we have to these tools that zoom in on any individual.
And what I wanted to say, do you think maybe, I've heard somebody say it's almost like right now we're at the Model T stage and it's going to really move fast. And we're going to look back at these early days and go, wow, I can't believe we were limited. But they believe, and kind of as you do, like 5-10 years from now, it could be revolutionary.
Well, in part, I agree with that, Brian. But medicine doesn't change very quickly. The medical community overall is highly resistant to change, especially this drastic one. So, unless we get a whole new look here, the average time from when there's a great potential for innovation and when it's actualized is about 17 years historically. I mean, it took 20 years for stethoscopes to be accepted back in 1816. So it hasn't changed over the years. And so unless we get the public, the consumer base, demanding this and fully activated, or we somehow get a whole different look among physicians, it's going to take a lot longer than it should.
Physicians, and you probably will agree, and we have a big old physician audience, I don't think we're the best group when it comes to change by and large. Most of us are resistant. I don't know if it's because you get a comfort level or you believe you've worked so hard to get to a certain point, but I think other industries have changed much more rapidly.
That's right. The medical community is a history of being perhaps, if not the most, certainly among the most resistant professions to change. And this one is especially difficult because it's coming with a lot of new knowledge, like, for example, genomics, wireless sensors. That wasn't stuff that was taught at this depth and at this level, modern level in medical school or during training. So you have that. You have reimbursement threats with all these information flowing potentially directly through the smartphone and tablet to the patient rather than the usual route, and doctors being the purveyors of all relevant information. That's going to be markedly different in the future. So you've got a bunch of things, with reimbursement challenge, the lack of control, change overall, knowledge gaps. It's a tough time to think about this, but it's going to happen. This is all inevitable. It's just a matter of when.
I wanted to ask you about that one question, too. It's a debate we have often, when CMIOs get together. It's usually either a debate of whether order sets should be standardized or if information should be sent directly to the patients, not through the physician. And people will say, well, they're not ready to handle all this information, or they can't make a determination when something might be a little bit off, or a radiology report might have been written legally and it probably is a fracture, but they don't want to say it. What about that? The person who more or less helps with the information, is that necessary, or do you think it should just be sent to the patients?
I think everything should be sent to the patient. And what's sobering to me is to see very recently a study of thousands of physicians, and 67% don't want the patients to get their office notes. Well, that's crazy. There's already been a big study called Open Notes about that. I'm sure you're aware. Mm-hmm. And that showed that, in fact, both physicians and patients, this is their choice. This is what they really want. And the centers that conducted that study, where the physicians were circumspect to start with, now it's routine practice, such as places like Geisinger. So we have to move to this transparency and respect for the patient, respect for the individual, and also offsetting some of that responsibility to each individual, because they are going to be getting a lot of information through such things as wearable sensors directly to their smartphone, and that is a shakeup, the likes of which we have not seen during our careers.
One last question I have to ask you, and it has to do with workflow and primary care docs who are out there. I talk to a lot of them. I work with a lot of them. And one of the issues is, well, you could almost go all day and all night now and not stop. And a lot of people are a little type A in the field of medicine. How do you control that? I mean, you could be checking people's labs at 11 o'clock at night online. You can do a million things. Where do you draw the line, and how do you control it?
That's where you embrace the digital world and let algorithms do that. That's where you let everything get processed by humans are not good at processing data like computers that are set to and all the algorithms that are properly validated. And so that's what we want, is to have all this torrent of data for each of the individual patients we're looking after, but only get the distillate, the juice of that, and only get notified if there's something that's needs immediate action. Otherwise, it's all done in a streamlined and very parsimonious fashion. So that's what we're looking at in the future, is relying much more on that signal processing and avoiding all the noise that most of us are often stuck with.
Dr. Eric Topol, we've run out of time. I want to thank you for joining and sharing your insights on primary care today.
Thanks a lot, Brian. I enjoyed the discussion with you.
If you've missed any of this discussion, please visit reachmd.com/primary care today to download the podcast and learn more on this series. Thank you again for listening. Until next time, I'm Dr. Brian McDonough.